Welcome back. Today we're going to cover suicide prevention. We'll talk about why suicide is such a big issue in jails, how to set up a suicide prevention system, and what Suicide Watch should look like. I'll also give you my own general thoughts and tips based on doing this for the last 9 years. If you're a master's or doctoral level clinician looking for instruction on how to conduct your clinical suicide risk assessment, then this isn't the video you want. I'm going to be talking primarily about suicide prevention from an operational perspective. We'll get into the clinical evaluation itself in another video. We've got a lot to discuss on this one, so let's get right into it. Jail mental health is a bit like Fight Club. The first rule of jail mental health is that no one dies in the jail. The second rule of jail mental health is that no one dies in the jail. The third rule is to always remember that suicide is statistically the most likely way that someone will die in your jail. With these rules in mind, let's talk about how we use layers of protection to prevent suicide. The first layer was already discussed in a previous video on nursing intake assessment. That is, you have to ask the arresting officer about any suicidal statements or actions they may have witnessed in their interaction with the arrestee. Then you ask the inmate directly during the nursing intake assessment. Now, at the time of this assessment, the medical staff should also be aware of any behavioral signs that might suggest an inmate is a danger to himself, even if the inmate denies it. For instance, you might notice cuts on the inmate's wrists, arms, or legs. This could suggest a tendency to self-harm. You might also notice a vacant expression or a flat affect when you're talking to the inmate, which suggests a dysphoric or hopeless mood. You also want to be on alert for statements that are not overtly suicidal, but are suggestive that the person might lack an interest in living. We call these passive suicidal statements. An example would be an inmate who says, "I just want to go to sleep forever," or an inmate who says, "I'll never leave this place." Any and all of these types of statements or behaviors should cause the inmate to be held in place and observed until mental health staff can come and do a more thorough evaluation. As discussed, we'll table the content of the evaluation itself for a future video. If mental health staff determine that the inmate is at risk for suicide or self-harm, they should then place the inmate on Suicide Watch. Where I work, we call this close observation. It's kind of a better term because you might want to observe an inmate for reasons other than suicide risk. At this point, the inmate should be moved to the mental health unit if your jail has one. If not, then you might move them to the medical unit or another special observation section. Ideally, you can put them in a safety or suicide-resistant cell. I'll try to put up some pictures here if I can. When I say suicide-resistant cell, what I primarily mean is a cell that minimizes opportunities to make a ligature, or something the inmate could hang himself from. Ligatures are the most common means of suicide in jails, so ligature points are public enemy number one. A suicide-resistant cell should also include a single bunk, preferably made of a composite material without any sharp metal sides. You want to make sure that there are no desks, chairs, or tables in the cell. These are things that can either be used to manufacture a ligature, or the inmate can climb up on them and jump off. You might think, how bad can you hurt yourself by falling off a table? Well, I've seen an inmate almost die from falling off of something 2 feet high and hitting his head on the ground. Additionally, you want to make sure there are no outlets in the cell, which is kind of something you don't want anyway for a lot of other reasons. You want to make sure the cell is well lit, with lighting that can be controlled from outside the cell. Some modern mental health cells allow inmates to dim and control their lights from inside the cell, and that's great for mental health care in general, but it's not good for inmates who are on Suicide Watch. You want to make sure the cell door is in good shape and is set up such that the inmate can't get a sheet or something in between the door and the door frame in order to make a ligature. If you have a mirror in the cell, it should be one that's made of metal and not glass, so it can't be damaged and used as a weapon. Really, the only thing that should be in there is a bed and a toilet. Another thing to be mindful of is the fire suppression system. If you've never worked in a jail, you may not know that a popular way to misbehave is to mess with the sprinkler system in your cell. Jails make these sort of tamper-resistant sprinkler heads to discourage this, but they're only tamper-resistant, not tamper-proof. If an inmate manages to damage it or pull it down, it could trigger the sprinkler system. This is dangerous because a lot of sprinkler systems have these little glass cylinders that break when the system is activated. And if your face is right next to it because you're up there messing with it when it goes off, then the glass could shoot out into your face and eyes when it breaks. The other thing to note is that once the sprinkler head is exposed, the inmate can then use that to make a ligature point. So if an inmate pops his sprinkler and you have to turn his water off to stop the cell from flooding, don't forget that the exposed sprinkler head is a risk point. You need to either have it repaired or move the inmate to a different cell. The last thing I'll say about cell interiors is that it can be helpful to have cameras inside these safety cells. Is this an invasion of privacy? Yeah, sort of. But you're weighing a person's right to privacy versus the risk that they kill themselves. There is a legal precedent for the prioritizing of safety over privacy for inmates. If you're curious, check out Hudson v. Palmer, 1984, and People v. Salaz, 1998. I'll put links to both of these cases in the description. Having cameras in the cell serves two main purposes. First, it allows for a secondary form of observation. If you're worried about an inmate trying to harm himself in his cell, you can put that cell up on a monitor in the control booth or in the counseling office, and that way anyone who's stationed in one of those locations or walks by can see what is happening in that cell. In my jail, all of the cell cameras can be accessed from any officer booth throughout the jail, and any monitor can pull up 16 cameras at a time. So if there's a high-profile inmate or someone that you're seriously worried about, you can have that cell camera pulled up on screens in front of 12 different officers throughout the jail. There's a very high chance that someone will notice problematic behavior in that cell, even if not everyone is directly responsible for monitoring that inmate. Second, having a camera in the cell by itself acts as a deterrent for any inmates considering self-harm. There's an old design for a prison called the panopticon. The panopticon was designed with a central pillar, which was basically the officer booth, which was surrounded with cells in a 360-degree radius. The idea was that one officer could monitor all of the inmates at once, because the inmates couldn't see into the officer booth, and therefore never knew when they were being watched. The same concept applies to the cell cameras. Inmates are less likely to try to kill themselves when they know someone might be watching them through the camera. Now, if your jail doesn't have suicide-resistant cells, then you don't really have a choice. You're going to have to house people on suicide watch in traditional cells. However, one thing you should consider, at least if you have multiple inmates on suicide watch, is to house them together. This is sort of the same concept as the panopticon again. It's pretty awkward trying to kill yourself when there's another person in the room with you. No one really wants to watch someone kill themselves, so if an inmate tries to do this when their cellmate is awake, there's a pretty good chance that the cellmate is going to hit the intercom and call for help. So think of that as an additional layer of safety. Okay, so what else do we do when someone is on suicide watch? I mentioned earlier that cell cameras are a secondary form of observation. The primary form of observation are what are commonly referred to as checks or clocks. What this means is that someone, usually from medical, mental health, or a corrections officer, physically and visually goes and checks on the inmate every 7 to 15 minutes. Some jails will use trustees to do these checks. Think of trustees as a set of helper inmates. They get special privileges in the jail for taking on various tasks and responsibilities. They're called trustees because relative to the rest of the inmate population, they're supposed to be the most trustworthy. I don't recommend using trustees to do your suicide watch, but if you don't have any other option, then do what you have to do. Now, why every 7 to 15 minutes? Why not every 15 minutes? Why not every 30 minutes? Well, according to the Department of Justice, 90% of jail suicides are completed by hanging or self-asphyxiation. Personally, 100% of the suicides I've seen have been completed by hanging. The reason this matters is that your body can go a few minutes without oxygen before you start to die. Every body is different, but for most people, after about 5 minutes without oxygen, you're probably going to have some permanent brain damage, and after 10 minutes, you're either going to be dead or have serious brain damage. This is why we never go more than 15 minutes without a check, and why we sometimes check in as little as 7 minutes. The panopticon principle applies here yet again. We check at random intervals between 7 to 15 minutes, and that way an inmate who's trying to time their suicide to happen between your checks never knows when you're coming back. Now, in my jail, we do a second layer of checks on top of this. So those 7 to 15 minute checks I mentioned before are performed by mental health staff. Then, officers assigned to the mental health unit of the jail also conduct watch tours 4 times an hour. So between these two sets of checks, the inmate on suicide watch is having someone check on them 8 times at semi-random intervals every hour. For an inmate to successfully hang themselves under these conditions, they would have to be very lucky or very clever. Next, what can an inmate have when they're on suicide watch? Well, not very much. The regular jail uniform is replaced by a suicide-resistant smock. These are usually green or blue, and they're made of a tough, not particularly flexible canvas material. They look like an uncomfortable robe without any sleeves. The basic idea is that these smocks cannot be easily used to make a ligature, and they're difficult to destroy. Once again, difficult, but not impossible to destroy because I've seen it happen. So they get to wear that, and then they get some flip-flops or some soft Velcro shoes. In a lot of jails, you get that setup and a mattress, and that's it. Nothing else is allowed in your cell. Now, this doesn't mean that you have to set up every inmate in the same way. I recommend that you start someone off on suicide watch like this, and then slowly give them additional privileges as their suicidal thoughts subside and as they demonstrate that they can be safe and use what you've given them appropriately. Suicide watch itself is always a catch-22. You don't want someone to have any opportunities to harm themselves, so you create conditions which make it very difficult to do that. Meanwhile, these same conditions are very depressing to be subjected to, so you don't want to do it any longer than you have to. And speaking of being miserable, I forgot to mention that when you're on suicide watch, you're locked down in your cell for at least 23 hours a day. Now, you might be able to come out of your cell for programming, say for therapy or recreation. However, you're only going to be allowed out with other inmates who are also on suicide watch. The reason for this is primarily those suicide smocks that we mentioned. We don't really want inmates with full uniforms, with shirts and pants, sitting in group with inmates who are wearing suicide-resistant smocks and don't even have underwear. Other than that, inmates on suicide watch really only come out to shower. Since suicide watch is uncomfortable and boring, I'll usually try to get some reading material for the inmates if I can. We maintain a small library of paperback novels, and I'll give a shout out here to my local library. I reached out to them to see if they would donate any old paperback books they didn't need, and they contributed a couple of large boxes full of books. If your jail doesn't have any books, then I recommend reaching out to local libraries or even local religious centers who might have some old Bibles, Korans, or other religious texts, because those are often requested in jails. As their mindset starts to improve and you start to trust that they're going to be safe, you can give the inmate back their clothes or give them paper and a safety pen so they can journal or write letters to their family. Safety pens, by the way, are these little half pens. They're very flexible. It would be hard to hurt yourself with them, and you can't really use them to stab someone. Now, what are you actually doing to help people when they're on suicide watch? Well, if you have the staff to do it, you should have an advanced level provider meet with the inmate every day. By this I mean a master's or doctoral level therapist and/or mental health prescriber. Given how short-staffed and busy most jails are, this meeting is probably not going to be longer than about 10 or 15 minutes, but at least you can see them daily. This can be a good place for unpaid interns or volunteers to provide additional support because they don't have the same sort of productivity requirements that most jail mental health staff do. The other primary intervention for these patients is medication management. We don't really force suicidal inmates to take medication. I don't think that's generally a very helpful intervention for suicide, but we can talk more about that another time if anyone disagrees with me. So, inmates on suicide watch can take antidepressant medication if they're willing, and if the prescriber agrees and thinks it's appropriate. I've met a lot of prescribers, and I don't know any who would have a problem with writing antidepressants for a patient who is genuinely suicidal. As discussed in a previous video, medications are the treatment of choice in jails because they're quick and cheap. Or at least most of them are. The antipsychotics can be extremely expensive, but we'll talk about that another time. So that pretty much covers what suicide watch is. Now, who can put someone on suicide watch and who can take someone off suicide watch? When it comes to putting someone on suicide watch, anyone should be able to do it, at least temporarily. If there's a reason to believe that an inmate is suicidal, that inmate should be placed somewhere that it's easy to keep eyes on him until mental health comes to evaluate him. Don't put them back in their section while you wait, just keep them where you can see them. Once mental health arrives to evaluate, they will make the decision about whether or not the inmate needs to be placed on suicide watch or whether some less intensive intervention is appropriate. We'll go through the process that mental health should use to make this decision in another video. But for everyone else in the jail, this is mental health's area of expertise, so I recommend you defer to their judgment. If you feel very strongly that an inmate needs to be placed on suicide watch and mental health doesn't seem to think so, then I recommend you place the inmate on suicide watch anyway, and call a supervisor to discuss the situation. As a mental health supervisor, I've had it happen a couple times where a corrections supervisor called me and convinced me that someone mental health had already cleared probably needs to be placed on suicide watch. My point is to trust your gut and get a second opinion if you need to. Remember the first two rules of jail mental health. When it comes to taking people off suicide watch, the industry standard is that you need to get permission from a medical doctor or licensed prescriber like a nurse practitioner or a physician's assistant. However, I think your policy should be a little more robust than this. The way I do it in my department is that no one can come off suicide watch without the permission of both a licensed prescriber and a behavioral health supervisor. Think of it like you're launching a nuclear missile. It's a potentially dangerous thing that you're doing, so you want two people to turn their keys at the same time. It's also a little extra protection in case anything does go wrong and you end up getting sued, because this way two licensed clinicians made the decision to discontinue Suicide Watch instead of just one. So what happens after you take someone off Suicide Watch? The first thing that should happen is, if you have one, you step the inmate down to a transitional housing unit. Think of it like a midway point between the tight regulations of the Suicide Watch section and the relative freedom of general population. If you don't have a step-down unit, you might consider temporarily housing the inmate in the mental health or medical section. It really just depends on how your space is set up and how much room you have. Then, as the inmate continues to improve, you can eventually transition into general population or wherever your classification department decides. Now, regardless of where you move the inmate, I recommend you schedule some follow-up appointments with anyone who was on Suicide Watch. In my jail, we have counselors follow up after 1 day, 3 days, and 1 week, and in each of these encounters, counselors are checking in with the patient to make sure that they aren't having any ongoing suicidal thoughts or serious mental health symptoms. Okay, so the last layer of suicide prevention we have is related to inmate movement. If an inmate is on Suicide Watch and needs to be moved anywhere, whether that's court, transfer to another jail, an outside hospital, or being released from the jail, any movement requires permission from a mental health supervisor. For court, the main concern is that different courts do things differently. Some courts are remote, some courts are in person in the same building, and some require driving the inmate to a different location. I'm pretty confident that our officers can appropriately supervise inmates on Suicide Watch in both remote court and court in our building. However, I have sometimes refused to let an inmate go to court in another location because I believe that there was a risk that the inmate might try to hurt himself en route or while being held in another facility's holding cell. In 9 years, I've done this maybe 5 times, so it's not very common. The judge might also be mad at you for doing this, but if you can provide a good rationale for why you thought it was unsafe, then I've found judges to be pretty understanding. When an inmate is being transferred to another jail, all you really need to do is to make sure that the receiving facility is aware that the inmate is on Suicide Watch. It's bad form to just send a dangerous inmate to another jail or prison without their staff knowing the risks. When it comes to outside hospitals, my jurisdiction requires an officer to be present at all times during the hospital visit, so this is pretty similar to the transfer scenario. Just make sure you notify your jail's transportation or medical department that the inmate is on Suicide Watch so they know to be vigilant. We don't usually take inmates on Suicide Watch to outside medical appointments unless it's for something serious. Finally, there will be times when an inmate is released from the jail on Suicide Watch. We often won't know this is happening until we get a call saying the inmate is being released, effective immediately. This can happen at any time. If you recall from a previous video, we talked about how inmates in my jurisdiction have to be released after 48 hours if no charges have been filed. Well, as you can imagine, a lot of inmates get arrested in the middle of the night. If you got arrested at 3 a.m., then 48 hours later, it will be 3 a.m. again. So you need to be prepared for these types of releases to happen at any time. Now, someone might correct me in the comments, but the last time I checked, local jails have no obligation to keep inmates safe after they've been released from the jail. So theoretically, someone could walk out of the jail and kill themselves in the parking lot and the jail wouldn't be liable. I'm not an attorney and every state is different, so don't quote me on that. But regardless of our legal obligations, we have an ethical obligation not to push suicidal people out into the street without a safety plan. It's worth noting that people released from jail have suicide rates 800% higher than the general population for the year after their release. So if someone is getting released while on Suicide Watch, the first thing you want to do is have the patient evaluated by your mental health staff. In my jail, there are master's level mental health staff on site between 7 a.m. and 10 p.m. almost every day. If something like this happens after hours, myself and another clinician take turns being on call to handle these situations. If your jail doesn't have mental health coverage like this, then you should consider going directly to an immediate detention or emergency detention. Your state may have different names for these things, but it's basically an emergency mental health hospitalization. Most, if not all, states have statutes that allow law enforcement to detain a suicidal person to transport them to a hospital. But if you have mental health staff in your jail to do an evaluation, you may not need to do this. A clinician can do a fresh evaluation, work with the patient on a discharge plan, and possibly contact a family member to form a safety plan. Alternatively, the clinician may determine that no safety plan is needed and the inmate is cleared to leave. This is most often the case when the inmate was on Suicide Watch due to malingering. or when incarceration itself was the primary cause of the inmate's suicidal thoughts. But more on this when we talk about malingering and suicide risk assessments. Okay, so we've covered quite a bit of ground on suicide prevention. Let me quickly recap the various layers of protection that we put in place. You have screening for suicide at intake. Anyone in the jail can identify someone as in need of suicide risk assessment. Counselors provide these assessments and put people on suicide watch as indicated. Once on watch, inmates are given a safety smock and housed in a suicide-resistant cell. A therapist meets with the inmate on at least a daily basis. A prescriber meets with the inmate to see if medications are warranted. The patient is visually checked every 7 to 15 minutes by a therapist and 4 times an hour by an officer. A camera in the cell provides additional passive monitoring. When the inmate is eventually taken off suicide watch, he's stepped down to a transitional housing section. Counselors then follow up after 1 day, 3 days, and 7 days to make sure there are no recurring suicidal thoughts. If an inmate on suicide watch is moved from a section, a mental health supervisor has to approve. It's kind of a lot, but each layer of this onion reduces the chances of having a suicide in your jail. So I know this was a long one. Something tells me that we're not done with this topic. As always, leave any questions in the comments below or send me an email. That's all the time we have for our session today. I'll see you next week.